My name is Adam Ramol. I'm with Linnea Medical. I'm the Professional Education and Training Manager. Tonight's webinar is titled Bringing Hysteroscopy to the Office, and it's hosted by Linnea Medical, but it'll be featuring Dr. Linnea Goodman, who's an REI in the Virginia area. A couple of quick housekeeping notes. This webinar will be recorded, and we'll be posting it later for viewing. If you have friends who wanted to attend but weren't able to, and anybody who registered will get a link to the recorded version of this. So if you need anything, let us know. The cameras are going to be off and your microphones are going to be muted. But don't worry, we are going to be able to answer any questions that you have. You should see on the right-hand side, you'll see a chat function. And the chat, it will be moderated, which means that we'll be watching for your questions, but they won't be public. So don't feel bad about asking a question, thinking, oh, maybe everybody else knows the answer. Go ahead and send the question. We'll keep an eye on those questions. And then at the end, I will present them to Dr. Goodman, and we'll go through it that way. The presentation is scheduled, the whole webinar is scheduled for an hour, presentation 30 minutes, so maybe go a little bit longer, and then plenty of time for question and answers, so we'll get all that done. Before the actual presentation, I'm going to introduce Dr. Goodman here in a second, but the first thing she'll do is go through a few questions that are survey questions, just so she can kind of get to know who she's talking about. So please give us answers to those, and we'll see those. So I will go ahead and introduce Dr. Goodman. She's going to be sharing her experience with hysteroscopy in the fertility clinic. Having graduated medical school from the University of Vermont, completed her OBGYN residency at the University of North Carolina, and reproductive endocrinology and infertility fellowship at the Cleveland Clinic, Dr. Goodman specializes in comprehensive and individualized fertility treatment with a focus on reproductive surgery. With a background in biomedical engineering, she's passionate about incorporating the latest minimally invasive technology and is currently working on bringing many of the procedures traditionally done in the operating room to the office. So without further ado, I give you Dr. Goodman.
Thanks so much, Adam. It's a pleasure to be here tonight. So as he said, the first thing I'm going to do is bring a couple questions to you guys. So the first question I have is, do you currently perform office hysteroscopy in your office? And so we see here this survey, and perfect, we've got some people adding in now. And so we'll give it a couple minutes to see where this comes. And as we put these answers in, I'll kind of talk a little bit about my background. So my original degree was in biomedical engineering. So I love new technology. I love trying the new equipment. And so I really kind of make it my goal to realize what's out there so that I can really give the best possible care to patients. And so that's where this kind of stems from. So it looks like a lot of you have not done office hysteroscopy before, and so that's exciting. So we'll be talking about that. Next question is, for those of you who do perform office hysteroscopy, what form of anesthesia do you use? So this will be the next question that we'll go through. So the options for this question will be no anesthesia at all, a paracervical block, oral medications that they take prior, such as Motrin, or you could even do like a narcotic, or IV medications. And so this is, we'll be talking about kind of what I do and what options are available for people to do out there. And so again, we're seeing a little bit of mix of people who do paracervical blocks or oral pre-medications, or even full-on anesthesia. All right, and then the third question is going to be, do you currently perform vaginoscopy? So this is a technique where you don't put the speculum in, and you just put the scope in the vagina. So option one would be yes, performed it for everyone, yes for selective patients, or no, you do not perform vaginoscopy. And this is another thing that I'm really excited about sharing with people. I think that it's an underutilized skill and can really make it more comfortable for patients. So I'm excited that a lot of you here today have not performed it, so that we can kind of walk through that. So we are going to get started now, and let's see if we can go back to sharing my screen. I'm going to stop sharing it, and then I will reshare it, and we'll make sure that everyone can see this. Perfect. Let me know if you cannot see my screen. And so I'm doing this in combination with Lena, and so a lot of these pictures and videos will all be done through the Lena Operoscope, and so you will see that featured here. So in the talk today is really going to focus on office hysteroscopy and to discuss the impact for patients and providers, and then outline really a step-by-step plan. So if you're someone that's absolutely new to office hysteroscopy, hopefully by the end of this, you will feel comfortable incorporating this into your practice. So as we know as practitioners, there's many different ways to evaluate the uterus, and we have a lot of tools at our fingertips. We've got ultrasound, we've got 3D ultrasound, we've got HSGs, we've got MRIs, and so I really love hysteroscopy because I am laying my own eyes on the pathology. However, in the past, doing hysteroscopy for a patient was a big deal. It is expensive, it's inefficient, it is logistically challenging to get scheduled. There's risks of anesthesia, there's needs for IVs, and it takes a lot of staff. And so this can be, a big deal. And so this was my setup when I've had a couple of different jobs. My first job at a fellowship was at a giant private practice. I then went to back to the academic center where I trained and did my residency, and I'm now in a smaller private practice that's affiliated with university. And so this was the university setup of a regular diagnostic hysteroscopy, and so huge amount of waste here, looking at a cost of about $1,000 per case. So, I had made a push to kind of make this more efficient, but when I had made this push, I submitted this whole business plan of how we were going to decrease costs, make it more efficient, and I got shut down at every way. And so really COVID made a big change for me in that all of a sudden these institutions were open to making things more efficient because they had been losing money for a lot amount of time. And so this really gave us the opportunity to kind of change the way things were done. So in terms of office hysteroscopy, we've been doing this for a long time. I mean, this is a study that is 30 years old now, and this looked at 13 gynecologists with no prior experience, and they did a number of office hysteroscopies, and they found that it was safe, it was feasible, it was effective, and the costs were extremely cost efficient in the office versus the hospital. So the question is, if this was proven back in 1996, how come all gynecologists aren't doing it today? And I think that comes down to, a number of barriers. And these are the barriers that we have incorporating any new technology. So some things to think about are we're worried about lack of experience on our part. We're worried about patient comfort. We are worried that the procedure is not going to go well. We won't be able to complete it. And then when we're bringing in new things, we worry about our clinic and we worry about the operational costs and staffing. And then we want to know about the reimbursement for the providers and then the cost for the patient. So let's walk through each of these in and of itself. So we'll start with barrier one, which is lack of experience. And there definitely is a learning curve with hysteroscopy. With any new skill that you pick up, you definitely have to kind of get used to it. And this was a study done by Perry et al. In 2017, and it looked at 439 patients who were undergoing office hysteroscopy. And it was timed based on an experienced surgeon and then resident surgeons that had zero experience. And so interestingly, the amount of time it took to do these cases was not very big, even when people were learning for the first time. So if you're a provider that does hysteroscopy, learning office hysteroscopy is something that is very easy to pick up. So barrier number two is concern regarding patient comfort. And this was an RCT that I did with back when I was at UNC, and this was comparing 100 patients, comparing saline ultrasound to in-office hysteroscopy without anesthesia using the Lena Operoscope. And we were looking at cavity eval prior to IVF. So before we put an embryo in, we want to make sure the uterus is perfect. And so we randomized 50 patients to get an SAS and 50 patients to get an in-office hysteroscopy. And we looked at a number of different variables, but specifically to this concern, there was no difference in time. So it was about 4 minutes for each of these procedures. And there was no difference in satisfaction. for the patient or the provider. And so this was high in both cases, both in the saline and the hysteroscopy. Now, pain scores were a little bit higher in the hysteroscopy group, but that was a 3.4 out of a scale of 10 versus a 2.4. So both of these really didn't even reach moderate pain levels. So both of these really on the mild pain levels. So barrier number 3 is apprehension that the procedure is going to go well, that we're going to be able to complete the procedure. And so there was a similar ease of procedure based on a saline ultrasound or a hysteroscopy. And so these were really high on a scale of 1 to 10. And so that was very reassuring. And then in addition, we found that there was a better cavity evaluation using hysteroscopy instead of saline. And this makes sense because if you're looking with your own eyes, you have kind of a better idea of what's going on versus just a saline ultrasound. So these are some different images, and I want to go through kind of what it looks like to do these office hysteroscopes. And so this is using the Linnea operoscope, and this is an evaluation of the uterus. And you can see here that we really get a good sense of what this uterus looks like for a diagnostic scope. And these are some images from that study. So the top series you're going to see is the hysteroscope images, and the bottom will be the same saline images in that patient. So these were patients that were randomized to the saline group and then needed a hysteroscopy afterwards. And you can really see kind of the better visualization using hysteroscopy. These were some polyps found during that time. And so you can see that even really micro polyps, that middle image, we wouldn't have seen that on a saline ultrasound, but on hysteroscopy, we were able to see these really small polyps and able to remove them. And does this impact fertility? These tiny micro polyps, probably not, but it does make me as a provider feel reassured that I really was able to remove everything. And so then this is looking at a recent lysis of adhesions case that we did. So you can see this patient had a recent D&C, and in the office, we're able to go in and remove this. Now, these patients are awake. There's no anesthesia, and we'll talk about that in a minute. But you can see here that we're able to navigate through this. And this is in real time. These videos are not sped up at all. And so it's really quick. It's essentially painless because these adhesions don't generally have pain fibers through them. And so able to use a set of scissors through the scope and be able to complete this right for the patient right in the office at that time. And so even in the case of we're doing a saline ultrasound and we find this, we're actually able to complete this right away. This is another case of a patient with retained products of conception. So it's a 40-year-old who had just had a miscarriage, and then she had a recent levels of HCG that had plateaued. So we had been worried about this retained products. And so we could have just done a saline ultrasound, but we opted to instead just go in with a hysteroscope. And we found this little area of retained products on the anterior surface that we're able to take down with a grasper. And what's nice about this is that it's not a blind D&C, and so we are not blindly scraping the entire uterus and removing areas that we don't want to remove healthy endometrium that has a possibility for scar tissue. We just want to remove that tissue. So barrier number 4 to incorporating office hysteroscopy is the operational and staffing concerns. And so something that I hear about a lot is that, I can't set up office hysteroscopy because it's too expensive to get set up. So what we want to think about in this kind of step-by-step guide is what are our capital costs? So do we want to invest a lot upfront and then have minimal costs going forward, or do we want to invest a small amount upfront and then have recurring costs? We also need to know our space constraints. We need to know our accessibility of anesthesia, our staffing availability, and then the cleaning, processing, and storage that goes along with all of this. So the first thing we have to do is determine our goals. What do we want to accomplish with this? Do we want just diagnostic ability? Do we want operative availability? Do we want to be able to do all hysteroscopy in our office, or do we just want to be able to do smaller cases? And then we need to evaluate the staffing in the space. And then, like we talked about, determine your initial investment versus cost per case. So 2 options here. Option 1 is reusable equipment. Option 2 is disposable equipment. Reusable equipment is going to have a higher capital cost. And then determining whether you want to do diagnostic or operative. So If you just want to do diagnostic, then a flexible scope is a great option. These are very, very small. They can navigate through the cervix, whereas a rigid scope is better for bigger pathology. But again, these have higher capital costs, but they do have lower operative costs. And that's because the equipment's already paid for. You just have to clean them. But they do have to be cleaned, and you need staff that's able to clean them. They may need to be serviced if they break. And you do need to train staff for these because you have to set them up. So these are a little bit more complicated to get going, but simpler once you have trained personnel and if that personnel is available all the time. In terms of disposable equipment, there's many different options out there, and I like to think that I've tried them all. I'd say I'm probably trying a new one once every couple months just to make sure that I'm on top of the game. And these don't have a super high initial investment. A lot of them have recording devices or monitors, and these you can actually just get set up with a TV screen, or a lot of them have built-in monitors. But there's no cleaning required of this. So this is a big thing here. And so it's very easy to get set up. So if you're someone that says, I want to get office hysteroscopy tomorrow, these are kind of the best way to do it because you can get them in your office right away and start using them immediately. Also, the setup and the staff is really minimal. I'm going to walk through a video and you'll see that it almost takes no training whatsoever on the staff's part. But these equipment are smaller, and so you may not be able to accomplish all the cases that you want to do with these smaller equipment. So in terms of setup, the big thing as you get started is patient selection and counseling. You don't want to kind of jump off the bat with your most difficult cases, with a cervical stenosis case. You want to kind of set yourself up for success. So in terms of cervical preparation, I do not give anyone Cytotec. I've found that I can get in almost anyone without any sort of prep, but certainly for the first couple cases, and honestly, probably the first 20 cases I did, I gave people Cytotec ahead of time because I was worried about it. And so giving someone 200 micrograms of Cytotec the night before and then the morning of is a good way to kind of boost your confidence that we'll be able to get in the cervix. Next on to anesthesia. So I actually don't use any anesthesia at all. So I don't pre-treat with Motrin. I don't give any narcotics or any anxiolytics beforehand. And so I basically go completely no anesthesia whatsoever. But there are a couple different options. And certainly in the first couple cases, as you're getting started, it's nice to know that the patient will be comfortable if it's taking a little bit longer. And so adding, some Motrin pre-procedure or a Xanax. And then certainly you can do a paracervical block. I don't because I use vaginoscopy, which we'll talk about in a minute. And then for the bigger scopes, certainly having conscious sedation by your anesthesia team is a really great option for those bigger cases. So in terms of setup, so you need two things. You need your scope and you need your fluids. And so in the bigger cases, it's nice to have these fluid management systems because they will monitor your fluid for you. I found that it's easiest just to keep it simple. And so hanging a bag of fluids to me is a really easy option. Now you do have to keep track of your fluids because you don't want too big of a fluid deficit. But I would say on average, I generally use maybe 100 cc's of fluids in these cases. So this is a video of the setup itself. And so I wanted to show this video because it literally takes less than a minute to set up the whole case. And so this is the recording module. And so this has the ability to take pictures and videos. So you plug in the scope itself to the recording module. It then comes with a set of batteries, and those batteries click right into the scope itself, and it has a screen that is attached. I then use a bag of normal saline, and I just use simple IV tubing. So I don't use cysto tubing. I don't use expensive tubing. It is literally just the IV tubing that you purchase to put an IV in someone. This attaches to the scope at the inflow. There's also outflow, so they have both inflow and outflow. And you can see that the water comes out at a pretty good rate just by hanging that bag. And then we're ready to go. And so my setup is really pretty minimal here. So once I've got everything set up, I like it to be really as comfortable as possible for the patient. And so I start with vaginoscopy with every single one of my cases, no matter kind of their parity, no matter their situation. I found that it's a lot more comfortable, especially when you have obese patients where speculums can be really uncomfortable. This is a really great tool. So the literature is pretty solid on this. There was a meta-analysis in 2020 that said that vaginoscopy was better tolerated, and as well that it was faster. It also has a lower incidence of vasovagal episodes, and the failure rate was similar to just using a speculum. So who are good candidates for vaginoscopy? Really everyone, but there definitely is a learning curve. So you want to pick a couple patients that are good patients to start with. And so you want to pick your low anxiety, highly motivated patients who will tolerate it a couple extra minutes. And for your first couple patients, if you want to pick patients that have had babies before, it does make it a little bit easier because they've had the baby go through that cervix. And so these are a couple of videos of vaginoscopy. And so the hardest part about this is figuring out the tissue as you go into the vagina. So you see here, so I put the scope right into the entrance of the vagina, and I start adding fluid here. And what's hard is that you're like, where am I? I'm totally disoriented. And so oftentimes bubbles will help you because they will follow their way into the posterior fornix. And so as you navigate the vagina, you'll see that there are rugated folds, and then you get to the cervix, and you're going to see the cobblestone area of the cervix. And in this patient, I chose this video because this is a nulliparous woman who had failed her first embryo transfer, and so the cervix is actually smaller than the diameter of the scope. And you'll see with really gentle pressure here, the scope will just go right into that cervix, even though the area was smaller. You can see the cervical crypts, and you can see the path. And the key to this is if you don't touch the sides of the cervix, it is essentially painless for the patient. And so this takes probably about 10 to 20 cases for this learning curve to get really comfortable with vaginoscopy. So this is another case. And so this, we're entering the vagina here and allowing the fluid to fill so that we can see. Again, those bubbles will help us kind of navigate where to go. And here you'll start to see the difference in the tissue of the cervix versus the vagina. And so the cervix, you'll see the bulbous area of the cervix. And so then you're okay, I know I'm at cervix, and now I just got to find the opening. And so you allow the fluid to fill, and you'll see that cobblestone area again. And this is a time here where I'll have a person that's helping me just put a little pressure on the bag so that it allows hydrodilation of the cervix. And you can see that we can now see the cervix. And you can see that the diameter of the cervix is really small. But as long as I use slow, gentle pressure and I'm navigating through, I'm able to enter into the cervix with really minimal difficulty, and the patient, it really tolerates it well. And so I've really found that it has really stepped up being able to do many more cases in the office. And so start to finish, so this is a diagnostic scope here, start to finish, it's really under a minute. And so these are scheduled in 15-minute blocks in my regular clinic days. So instead of going to the operating room and having it booked for 45 minutes and needing to take 2 to 3 hours off from clinic, I did that whole case in under a minute. So the next question is, how much does it cost? How much does it cost to providers? How is reimbursement done for patients? And so this is the old data, but really quite striking because it's going to be higher now. This is the average total charge for hysteroscopy over the time frame of 1993 to 2008. And you can see that the charges for hysteroscopy are crazy high. I mean, we're talking $10,000 to $15,000 in these charges. And a lot of that is the facility fee, because the hospital is charging for their operating room, charging for the lights to be on, charging for the team. And so, and then charging for the setup. So this was the old setup in the hospital. And during COVID, we were able to pare that down a lot and getting it down to about $157. And so this is still pretty significant if you're paying for gowns, you're paying for light handles, you're paying for drapes, and you're paying to autoclave all these instruments as well as Ratex and all these things. So still pretty significant costs here. Whereas alternatively, if you do a disposable scope in your office, it can be done with minimal supplies. I mean, this under buttocks drape here that's in the top left, we used this until it went back order. And then we realized that trash bags work just as well. And so I actually just use a 13-gallon trash bag under the butt instead of using a sterile underbutt drape. I don't use sterile gloves. I just use regular gloves. Like I said, I just use a 500 or a liter bag of fluid and then some IV tubing. It literally cost me a total of $3 for my setup. So going from $1,000 to $150 to $3 for my setup. And then looking at the, the cost comparison. So this was data from, my previous institution. And so it was, about $9,000 charge to patients and about $2,900 cost for, setup, supplies, staffing, overhead, all the things that go into staffing a whole operating room. And so doing them into the office saves about $7,000 to the patient and then saves about $2,600 to the system. So it's kind of a win-win to both patients and providers. So in terms of reimbursement to physicians, so there was a really big change in 2018. So it used to be that if you took a patient to the operating room, you got a surgeon fee. And if you took someone to the OR, or if you took the operating room or you took the office, you got your surgeon fee, and that was the same in both places, and that was about $240. I think I was getting paid $300 for a polypectomy in the OR. In 2018, Medicare was like, oh wait, if we bring people to the office, then this is going to be a game changer, and we're not going to have to pay these facility fees. We're not going to have to pay this 10 grand. And so they were like, I know, if we pay the physicians more to do in the office, this will drive a lot of hysteroscopy into the office. And they started reimbursing office procedures way more than the OR procedures. And so the Medicare allowable for a 585 or 58558, which is a polypectomy or a biopsy, was $1,300. And so this was a huge step up and really has better reimbursements for us in the office now. So in terms of the financial impact for patients, if they have insurance, most of them just get a copay. And what's really nice about this is that my financial counselors can reach out to the insurance ahead of time, and they can get a sense of what they're going to be responsible for before the surgery. And so this is a big change from the operating room. You're in the operating room and people have no idea what they're going to get a bill for. And so they're worried they're going to get a bill for $10,000 and they don't know what their copay is, what their deductible is. And so it's really nice upfront to be able to say, okay, you're going to have a $20 copay for this procedure, or you're going to have a $200 towards your deductible for this procedure. And then if they don't have insurance, this is a much more affordable option for them because you can do the whole thing and they don't need the facility fee that goes to the hospital or anything like that. And then for providers, like I talked about, we have better reimbursement rates, and you can be more productive in the office because you're not spending a whole half day to go over to the hospital and do a hysteroscopy. You really can just sprinkle them in your clinic wherever. So I wanted to walk through some new exciting things that I'm doing with office hysteroscopy. And this will be presented at our annual meeting, the ASRM this year. And so what I am doing is I'm starting to use office hysteroscopy for pregnancy of unknown location. And so and these are people that, for me, I'm a fertility doctor. So for me, I'm finding out a PUL very early in the course. So, someone comes in, they've had an embryo transfer, or they were pregnant from an IUI, and I get a first beta, and then that beta does not rise appropriately. And so it used to be that we would follow, and then if still not rising appropriately, we would either take to the OR for a D&C or do methotrexate right out. And most of the time, patients actually just got methotrexate right off the front because then we didn't have to go through the rigmarole of doing the D&C and floating for products. But what I'm starting to do is I'm starting to look in the cavity because giving methotrexate has its own set of risks. You have to wait for 3 months after you receive it. And so that's really hard for these patients who are trying to get pregnant. And so this was a patient who had an embryo transfer. Her initial beta was 100, repeat beta was 135, which we know is abnormal. And then repeat 2 days later is 134. So now, we're like, okay, we're pretty sure this is, plateauing and this is an abnormal pregnancy. So we waited a couple more days and we had a rise. But again, that rise was abnormal, 353 and then 364 and then 380. We did a scan. We see maybe there's a possible gestational sac, but we're not sure. And so we're like, you know what? Let's take a look with our office hysteroscopy. And so this is the case of the office hysteroscopy. So again, we're doing vaginoscopy and coming in here into the uterus. And you'll note once we get in that on that posterior side, we see that little abnormal sac. And so with this little abnormal sac, we can be sure that this is not an ectopic pregnancy. And so we're able to go in with a set of graspers and able to remove this little sac. And then we're able to follow those HCG values down, being confident that this is not an ectopic pregnancy and that this was an abnormal intrauterine pregnancy. On the alternative side, if we'd gone in and seen nothing, then we could be sure that this was an ectopic pregnancy and give methotrexate, knowing that that was really essential that we give that methotrexate. So in conclusion, I hope that you guys have come along with me to find that office hysteroscopy is safe and effective and well tolerated. And really, it's pretty easy to implement once you establish what goals you have. And it's really beneficial to both patients and providers. It is logistically easier in that, I mean, oftentimes I'll see a patient, I'll do her saline, and I will schedule it right then, either for right after that procedure, or, can you come back in 2 days and do this? And so I can even schedule it myself because it's just in my clinic. You also can avoid, all the things that go into it being at the hospital. You can avoid your pre-op visit, your registration, COVID testing, et cetera. I do, any diagnostic scope, any polyp less than a centimeter, and any adhesions that I think I can do with a simple set of scissors, I'll do with the disposable scope in the office with really little to no anesthesia. And it's really efficient, it's really fast, and really well tolerated by patients. And so overall, I think leads to better patient and provider satisfaction. So a couple references here that we talked through, and then I would love to answer any questions that you guys have.
Hey, Dr. Goodman, can you hear me?
Yes, I can hear you.
Okay, that was an amazing presentation. And I'll be honest with you, there's not a lot of questions because I think you covered pretty much everything. It was very comprehensive in a good way, and you covered a lot of good details there. Just one thing I want to add, as far as the vaginoscopy, we found in going out to our customers that they feel like operoscope, especially with the key opinion leaders, the high volume people like yourself, that operoscope lends itself very well to vaginoscopy, but not a lot of people do it outside of the big institutions and things like that. So just so you know, we're going to schedule another webinar specifically on vaginoscopy. And we also found out that we're going to be on the AGL webinar list for April of next year to do one on vaginoscopy. So that's really, we see the benefit as obviously you do. But one of the questions we did get was, obviously you've done a bunch of these, you've got great videos, you've got your setup done. Honestly, what were the first handful of cases like when you started doing operoscopes?
Yeah, it's a great question. So anytime I try new equipment, I try it in the operating room with someone asleep. And so that is kind of the most important thing, I think, because you don't want to be fumbling around when a patient's awake. And so I always have the rep in with me, and so I do like a dry run. And like I said, I like to try all the new equipment. The Lean is my favorite, but I like to say the Lean is my favorite, knowing all the other stuff that's out there. And so whenever something new comes to the market, I always try it. And so I do a dry run before I ever see a patient. And I make them set up everything. We attach the fluid, we put my instruments through it. And then the first time that I do it, I make sure it's a patient that I know well. And I say, hey, I'm trying out some new equipment. I've done this procedure 10,000 times. I have my old equipment all set up in the back if I need it, but I'm trying out this new equipment. Just want to make sure that's cool with you. And they're always like, oh yeah, because I pick them very carefully. I pick people that I know that trust me. And so then when they're like, yeah, that's totally fine. And so then I have the rep in there with me when I'm setting everything up, and so that they can kind of walk me through the setup. And then I pick people that I'm anticipating relatively easy cases for the first couple. So, a small polyp, a diagnostic scope. I'm not going to be doing these like giant retained products, these big fibroids. I'm going to pick something that I know that I can accomplish with even with, with the easiest of cases. And generally I'll pick something that, I know that someone's had a baby before, so it's going to be easy to get through the cervix. And so I set myself up for success for my first couple cases. And then if it goes beautifully, a time or two in the OR, then I'll just, I'll try it on an awake patient, or I'll be like, nope, don't like this equipment, and move on.
Great. And on that patient selection topic, one of the folks out here asked, they have a lot of postmenopausal women who need evaluation. How do they do for office hysteroscopy? Anything special you do for postmenopausal?
Yeah, for these subset of patients, I would do Cytotec, just because their cervix can be so much more stenotic than the premenopausal patients. And so with postmenopausal women, if they've got a big thick stripe, so if they're doing this because their stripe is 10, 12 millimeters and they've been bleeding, then I don't necessarily do a cervical prep. But if it's someone that has cervical stenosis, or you're worried about like a polyp, or like a little polyp but the lining is thin, then I will do Cytotec for them, because they will have a much harder cervix to get into.
Gotcha. And do you, as far as the other patients, are you timing those procedures with their cycle, or do you do any kind of medical pre-treatment other than the Cytotec?
Great question. So I've gone back and forth in my career. When I first started, I put everyone on OCPs so that their lining would be super thin, and so that their pathology would really stick out to me. When I first started, so I did my training at Cleveland Clinic, where I did a gajillion surgeries, and my first job was to be a reproductive surgeon. And I entered the arena as this, like, I was the reproductive surgeon, but I totally had imposter syndrome, and I was like, I actually am not an expert. Like I don't want to tell anyone, but I am not an expert in this. And so I went way overboard on the prep. I went way overboard on like making sure everything was ideal to set myself up. So, I did Cytotec for everyone. I put everyone on OCPs. I made sure that their lining was thin. And then as I started to do tons and tons of cases, I realized that I don't actually need these crutches anymore. And I was able to slowly wean these things off. And now I don't do any of it anymore. And so now I actually, I don't want someone to be pregnant, obviously. So I don't want it to be in the second half of their cycle. But most of my patients are infertility patients, and they want to get done things as fast as humanly possible before their transfers or after their failed transfers. And so I actually don't mind doing it in the follicular or luteal phase, as long as they're use protection during that month.
Gotcha.
And so their linings will be thicker mid-follicular, and then luteal, we will see that contracted lining that will look a little more polypoid because they are luteal. But if I'm going after something like an adhesion or a retained products of conception, then I don't mind, kind of what the lining looks like. I just know that I'm going to need a little bit more pressure. And so then I'm going to have my person with me. And my person that's helping me is an MA or a nurse or a medical student or a resident. It's not someone, experienced. It's just whoever I have on hand. And the way that they help me is they just literally squeeze the bag, and it will, a little bit distend the uterus and give me a little better visualization.
I just got a very interesting question. I don't know if you'll be able to answer this one. Why do gynecology oncologists still believe that we spread cancer with hysteroscopy? How do we dispel this myth?
Yeah, that's a gret question. It's certainly not one that I can answer. How do we dispel this myth?
Yeah.
I think that you kind of have to weigh the pros and cons. I mean, I think that potentially if you have a friable cancer, and you go in with hysteroscopy and you're putting fluid in there, and that cancer then spreads, and then those cells spread through the tubes, I mean, potentially you are seeding endometrial tissue into the abdomen. But I think the benefit of doing a hysteroscopy is you can do a directed biopsy. And so the data is pretty good out there that doing a blind endometrial biopsy misses a fair amount of complex atypical hyperplasia and cancers, because just like that retained products that you saw, if you have a localized cancer that is not huge, you could very easily miss that endometrial biopsy. And so is there a possibility that you put fluid in and then that fluid comes out? There, I guess hypothetically there is that possibility. It's the same thing with laparoscopic morcellation of morcellating a fibroid that could be a sarcoma. But I think the benefit of getting a directed biopsy probably outweighs that hypothetical risk of that. I think the other thing that's reassuring is that, when we do a hysteroscopy, laparoscopy, if you're doing a the hysteroscopy with minimal fluid pressure, a lot of that time, especially with vaginoscopy where you're not using a tenaculum, a lot of the time that fluid will just come right back out the vagina. And so that fluid, and that's why it's not as painful for patients, because if you're bringing fluid in and that fluid has an avenue to come out, then you don't have that contraction of the uterus that causes all that pain. And so similarly, if you have an endometrial cancer and you've got fluid coming in, you take a biopsy and that fluid's going to come out, opposed to going through the tubes and spreading the abdomen.
And I think you're exactly right on that. And as far as the pressure, the distension of the fluid, of the uterine cavity with fluid, and we have, as a company, have kind of backed off on people using pressure cuffs and things like that, because they tend to over pressurize the system, including the hysteroscope itself, and more pressure and all of that causes more problems. So there's more benefits even to like, yeah, I think you said you just hang a bag of fluid, and if you need more pressure, you have the MA give it a little squeeze to get it going, kind of thing, and not much more.
Yeah.
Then instrumentation wise, do you have any particular instrument that's your go-to, and what percentage of procedures are you able to do in the office as opposed to having to take them to the OR? Kind of ballpark.
Yeah. So Adam, close your ears for a second.
Okay.
But my go-to is a reusable grasper.
Okay.
Because it is reusable, and so I don't have to spend the money to do the disposable grasper. But I do have all of my disposable graspers when my reusables are dirty. So, I only have a couple of reusable graspers, and then I have a number of disposable products that I have. I do love the disposable scissors because they are sharp 100% of the time, though. So my reusable scissors get dull really easily, and they're very expensive. But my disposable scissors, for the price, are great because they are sharp every single time.
Well, like we always say, and it's a bit of a plug, but we have a range of instrumentation, so we have whatever you like to use. So if the scissors are what works best for you, then great. If a reusable grasper works great for you, or if the lasso, whatever it is, hopefully we can always have some instrument that benefits. And what percentage of patients do you think you're taking to the OR as opposed to the office?
Yeah, so I do about 20 cases a month, and I just operate. There's 3 of us, and we operate on Wednesdays, and so we're every third Wednesday. We do all of our hysteroscopy here in the office, but we have anesthesia here in our office because we do egg retrievals. And so, I generally do 5 or 6 cases on my Wednesday that are using anesthesia, and then I do about 15 cases a month without anesthesia. So about 75% I'm doing with the Linnea scope, and about 25% I use, a big rigid scope.
Gotcha. Let's see. I'm not even going to ask you about the trash bag. I'm going to let that one go. That's the first time I've heard trash. But quite honestly, a lot of the procedures, you said, comes down to cost of the procedure. That's big questions that we get from doctors, is cost of the procedure, the amount of equipment. I think you addressed that great. It's a lot less equipment. It's a simple and easy setup. You don't have to buy all the fancy schmancy stuff, and you can do a quick. What's your time limit on a procedure in the office? Actual scope time. Is there a point at which you go, I gotta stop?
I think as I have had more and more experience, I know very quickly whether or not I'm going to be able to complete it or not. And so if it's something that I feel that I can complete and the patient's doing well, I will continue as long as she's doing well. I definitely have a deficit. My deficit is 2 liters. I've, knock on wood, never reached my deficit in office hysteroscopy. I actually don't think I've ever used 2 bags of fluid in the office. Now, certainly with my fibroids, when I'm doing them under anesthesia, I will go through much more fluid. But in terms of, so generally pretty much all polyps that aren't like giant polyp gardens, I can do. When they're bigger than a centimeter, they're hard to get out through the cervix because I'm not dilating the cervix. And so those oftentimes I'll take to the operating room and use the hysteroscopic morcellators for those when they're really big or multiple. But so usually, and the big retained products I'll do under anesthesia with the hysteroscopic morcellators as well, because those can get bloody sometimes. And I like to be able to monitor my fluid a little bit more closely because oftentimes patients will resorb more fluid. But if it's polyps or adhesions or or it's just diagnostic for Mullerian anomalies and the patient's tolerating it well, honestly, within a couple of minutes, I know if I'm going to be able to complete it or not.
Gotcha. And I had, let's see, polyps. Oh, hemostasis. Do you ever have any issues with hemostasis when doing polypectomy?
Yeah. So with having my person that's helping me squeeze the bag, that's my biggest tool to get hemostasis, is I really add that pressure to it. I did go over and train in Spain for a bit and watch them do hysteroscopy, and they use a huge amount of pressure. So they'll routinely crank their pressure up to 200, and they can see beautifully with that. And so just giving that big squeeze once will allow that uterus to tampen on that bleeding. And then if I'm having trouble still, I'll use a grasper or the tip of the scope and put it directly on the uterus, on the place that's bleeding. And so I'll just use that as pressure, as if it was my finger, to stop it.
Gotcha. One other question. We still got a few minutes. Staff training. Do you have a lot of staff turnover? Is that something that you run into? I've had doctors say that new staff, they're a little apprehensive because it's an office procedure and the patient's awake looking at them and that kind of thing, but they get over it pretty quickly. So how does your staff embrace the office procedure?
So this is something I learned from Dr. Linda Bradley, who's here, which is super exciting. So she was one of my mentors at Cleveland Clinic. And so it's so great that she's here because I hear her voice in my head often. But one thing she taught me is that you always have to know your own equipment. And so I never depend on anyone else to know the equipment. And so if I had 4 hands, I could literally do the entire thing myself. And so anytime I have a new person with me, we always walk through it ahead of time. And I'm like, this is what I'm going to need you to do. And really all that I really need them to do is squeeze the bag if I need them to squeeze the bag, and unwrap my instruments if I use instruments, like unwrap the grasper or the scissors.
Right.
And so those are 2 things that I don't need a lot of help with. And so I think that my office staff actually loves assisting me with them because it's a very satisfying procedure to take something out and the patient sees it and the patient's grateful. And so they really enjoy doing them with me. And whenever we have a new person, they're always like, oh, go in it. It's super fun to watch. And so I found that it's really easy to take new people and to train them. And like I said, I'll do it with a med student who's never seen it before. I'll do it with a resident. And so that makes it really great. Now, in the operating room, when I use the bigger equipment, I do have dedicated staff. And so that makes a huge difference because that is hard to train. And so if you're thinking about adding the hysteroscopy using some sort of anesthesia with reusable equipment, that is a bigger undertaking, and you do need staff that's dedicated, and potentially, a scrub tech who knows how to handle sterile equipment and wash equipment. And so that's going to be much more of an investment.
Gotcha. And I'll ask one more question. You mentioned in the larger institutions, what would you recommend to, our bread and butter really is the private docs, that they need to have a procedure that's cost efficient and time efficient and all that kind of stuff. Some of the bigger institutions, they have other avenues for doing things. What do you think is the best way to get that big institution to buy into office hysteroscopy, regardless of whether it's Operoscope or anybody else?
Yeah, I think they have to be. It's kind of like if you have, someone that you're trying to take to rehab. I think they have to be ready for the change themselves. Because when I was at UNC, when I first got there, I was horrified at the waste because I had come from a private practice, and like you saw that $1,000 of equipment, and I wrote up this whole business plan, and I said, look how much money we could save. This is how we can do it. This is how I'm going to roll it out. I'm going to start with me, and then we'll branch it out to other physicians. And they basically took it, and then I never heard anything back. And I followed up a couple times, and they were like, yeah, we're working on it. And it totally died, and no one was interested at all. And then COVID happened, and UNC was losing a lot of money because all their OR shut down. And they sent out this email to all the OBGYNs, all the surgeons, and said, if you have any ideas how to be more efficient and save money, please submit them. And I literally took that email that I had sent 2 years prior and resent it to them and said, hey, here's my idea of how to save money. And they were like, this is amazing. We're so excited to institute these changes. And it was literally the exact same thing that I'd sent 2 years ago. And so UNC was able to implement that. And that's when I introduced the disposable equipment to UNC, because I said, look at how much money I'm actually saving, because we're not paying for the OR time. We're not paying for the staff that's here. We don't need to pay the overtime of the staff that stays late because the cases are being pushed back. Because it's usually hysteroscopies that are at the end of the day, because the big cases go first and the minors go at the end. And so then you're having to pay your extra overtime float staff, and you're calling people in to cover your last cases. And so if you can spend, a fraction of the price on a disposable instrument and do it in your clinic in the time, it actually saves the hospital a lot of money. And so I think they have to be ready, and I think you just got to show them the numbers.
Yeah, it was one of the few good things to come out of the pandemic. We actually had a lot of people. You weren't the only one that called and said, yeah, we can't get people booked into the OR for minor hysteroscopies, so we're going to start doing them in the office. And so I guess some good did come of it. We're almost, we still got a few more minutes, but I've asked you all the questions.
Yeah, I think there's one that just popped up on what maximum size try and removed.
I think you said about 1 centimeter.
Yep, about 1 centimeter. Yeah. And if someone's had a baby, or they're super motivated, oftentimes if they're like, I don't want to have anesthesia, I don't want to go to the OR, then what I can do is I can actually just disconnect the polyp, so I can just remove it from its blood supply. And then oftentimes they will just go necrotic and come out through the vagina. And so I have had people that have really not wanted anesthesia for one reason or another, and I've either cut them up into a couple pieces and taken them out, or just disconnected them and let them be and let them come out on their own.
It's funny you would say that, because I've heard that in the last couple of years from a couple of other KOL type docs who have said that, and I've repeated it because doctors also feel like they've got to get every bit of that polyp out, and I'm not saying it, you guys are saying it, that it'll necrose and pass. It's probably, is that unpleasant for the patient, or as long as she knows it's going to happen, it's not a big deal?
Yeah, and it hasn't been. It usually just comes out with her period, and so it just looks like a little bit of tissue. And I warn them. I say, this looks like. And most people who have these big polyps are like, I've been having crazy clots for the past 6 months, so it's a no-brainer. Yeah. They're like, oh yeah, totally fine.
It's nothing. And plus, on a hysteroscope, it looks like it's gigantic, and it's actually
right.
So, and I love. You probably saw Dr. Bradley's comment.
I know.
Their hysteroscope is their stethoscope, which is fun. But anyway, unless there's any other comments from you, I think we've answered all the questions. And like I said, this is fantastic. The videos embedded in your presentation, I think, are worth a million words. And you've laid out a really good case here for people to not be afraid of doing hysteroscopy in the office. We'll try to tackle the vaginoscopy thing, in, like I said, some other settings. That one seems to be a little bit tougher, but even without it, still laparoscope is a pretty good option. So can't thank you enough for all the time and your preparation in this. Also, to all of those of you who attended and sent in questions and took the time out of your busy schedules. As I said, we will post this and get back to those people who either if you want to watch it again, if you had to jump out for a minute, and other folks that you think might be interested, we will post it. But unless there's anything else, I'll let you go.
Sounds great. Well, it's such a pleasure to be here with you guys. And if you guys have any questions, feel free to reach out. I'm always happy to kind of chat through things, and I'm excited for this to take off even more.
Us too. Thanks again. Bye-bye.
Yeah. All right. Good night.